Hello everyone, I am Anna and our presentation is on the process improvement of ER wait times. I will be discussing process mapping. Angelina will identify where waste is occurring and the reasons for it. How to reduce waste will be covered by Chase, and how to reduce defects will be covered by Natalie. Finally, Nian will discuss a strategy on how to execute reducing waste and defects. Process improvement is a proactive task of identification, analysis, and improvement on the existing organizational process toward optimizing and meeting new quality standards. Process improvement in the healthcare setting is among the fundamental drivers of a transformational strategy aiming to lower healthcare costs while improving the quality of care. Healthcare processes impact patients' experience, operations, and clinician job satisfaction. Overcrowding in healthcare setting is a major precipitator of waiting time as a lean waste in the healthcare setting. There are several studies done to compare this rate among patients who arrive during the congestion periods, which have consistently depicted a greater mortality rate during the time of congestion. Increased hospital lengths and a high death rate, as well as established the consequences of increasing waiting time in the AR. Overall, overcrowding in the emergency department, increasing waiting times, lengths of stay, ambulance diversion, patient mortality, medical errors, and harm to hospital secondary to financial losses. A process map is a planning and management tool that visually describes the flow of work. The above diagram depicts the ER process map that shows the workflow from the time a patient comes in to the time the patient is discharged. The patient arrival at the ER can either be through an ambulance or walk-in, which is followed by mini registration and triaging. If an ED bed is required, the patient is taken to ED bed and then enters the process of nursing examination and physician treatment to achieve stabilization. Afterward, the physician determines if a consultation is needed and admits the patient in the inpatient ward, where the patients receive care until recovery and then discharged. Patients can also be admitted from outside hospitals and referred directly for admission through the emergency department. From the triaging, if an ED bed is not needed, then the patient enters the provider direct queuing PDQ process. This process places an emergency care physician and triage. From here, the patient can either be discharged home or be determined to require an ED bed and through wait in the waiting room for admission. Throughout this ER process, there are several parts of the process that may result in significant wait time for the patient. Angelina?
Thank you, Anna. Waste identification using the Kaizen method. Kaizen focuses on waste elimination, productivity improvement, and achieving continuous sustained improvement. We chose to use Kaizen to identify the waste occurring in the ER due to long wait times. This is used in conjunction with the lean method when trying to reduce waste and improve production. Out of the 8 wastes identified by Kaizen, we focused on 5 wastes. Defects, due to failure to meet customer expectations because of the lengthy wait times and lack of customer-oriented service. Waiting, of course. Transportation, waste from traveling between ERs, trying to find better timing to be seen, or going back home to try to avoid long wait times. Motion is wasted from patients being moved from room to room when they are available, and staff being idle when they are not providing direct patient care. Also due to short staffing, having to go back and forth between patient rooms multiple times because they have forgotten to address certain needs, because they are burned out from a constant stream of patients and potentially no breaks. This leads to extra processing as a waste because the workload for many care staff members is doubled and due to the lack of staff. Next, Chase will discuss reducing waste.
Thanks, Angelina. Hi, everyone. My name is Chase, and I will be identifying ways to reduce waste in the ER in relation to wait times. Long wait times in the ER are governed by the availability of space and staff. This is supported by rapidly conveyed results as they become available in order to turn over rooms to allow patients to flow in and out of the ER efficiently. Once results are conveyed, the decision to treat patients, discharge them, transfer them, or have them wait for a room in the ED is determined by ER staff. Early in the presentation, Anna had an excellent diagram depicting the course of travel a patient might experience through the departments. There are several spots along the route where waste and defects might occur, but I will be focused primarily on reducing waste and idle time, transportation, motion, and overprocessing throughout that system. Firstly, closed-loop communication and rapid availability of results enables patients to move through their triage process. EHRs like Epic, whose results are immediately available across every platform of the hospital, allows staff to gain access to results and view orders without consulting different programs. This also reduces staff motion and overprocessing caused by the reordering of exams when they are not properly visible or timely or missed. Just the same, Epic also features small icons that tell staff certain tasks are done and that patients may move through to the next portal, labs, radiology, EKG, those kinds of things. This tells others that workups are complete and that other tasks can begin. We see this constantly in radiology when we go to check in on a patient in the ER if they're ready, and oftentimes notes like check back in 15 minutes, IV and labs first are common on exams. An outside hospital I used to work at had a RAD status that told imaging if patient was ready by assigning them a status viewable by all staff. That way we wouldn't waste the motion walking to get the patient only to have to come back when this could have been spent completing a different exam. Correct, timely orders that encompass what the patient needs the first time around also reduce motion for staff and repeated trips to imaging for the patient. It also reduces overprocessing by the radiologist and other physicians who read the repeated or additional studies and make uniform decisions off the results. Proper allocation of resources can also vastly reduce waste in the ER. Proper staffing levels to ensure prompt and safe patient care, availability of necessary equipment and supplies for care, and efficient pathways to and from imaging can all accelerate the care stream process. Beginning with staffing, nurses make the ED go around. They move patients forward in the care stream and activate and complete orders submitted by physicians. Understaffing plays a critical role in overcrowding and contributes to longer wait times. It also contributes to poor patient satisfaction and results in patients leaving before they are seen, a loss in revenue for the hospital, and a risk that such patients will return with worsening conditions due to delayed treatment. Lastly, strategic staffing must be addressed. For example, EDs are usually busiest on weekends and nights, both times when doctors and nurses don't want to traditionally work, which means that they are usually short-staffed. Just as well, access to adequate supplies of working equipment like EKG machines, cardiac ultrasounds, Dopplers, IV pumps, stretchers, and wheelchairs allow ED staff to reduce waste produced by patients waiting for equipment and workups. The time it takes to find a piece of equipment not immediately available to you or out of your way adds up a lot throughout the shift and may represent a sizable waste metric if measured over time. Likewise, the layout of the ER makes a huge difference when it comes to reducing transportation and overprocessing waste. For example, our imaging department is actually coupled in the center of the ED and is accessible by at least 4 different entrances for staff and patients alike. CT and X-ray can coordinate exams with the radiologist who's just around the corner, and reduce patient travel, deliver prompt results, and if necessary, add additional studies while the patient is still in imaging rather than returning to their waiting location. According to Venieri, Pinero, and Coletta, creating specialist pathways for patients admitted with conditions that require an advanced workup or a specialist consult may reduce overprocessing and set the patient on the most efficient pathway for their ED visit. Pregnant women or those seeking eye specialist care for vision or ocular injuries can be evaluated according to a set protocol with the proper personnel, which allows the ED staff to keep up with the needs of all other admits to the ED, not falling into these pathways. Moreover, it's a way to offload care early in the triage process rather than wait for consults and results through the regular chain that might waste time. Reducing waste in the ED, most specifically motion, transportation, waiting, and overprocessing, can all be possible through properly analyzing areas that represent the bottlenecks of care where patients and staff are experiencing excess time spent idle. Working backwards from that step and asking each area how it's impacted by others ensures you're addressing the system as a whole and not just its symptoms. This kind of broad spectrum analysis is invaluable to healthcare change leaders. Next, Natalie will be discussing ways to reduce defects. Thank you.
Thank you, Chase. Hi, my name is Natalie. And long wait times in the ER coupled with poor quality ER care for a host of medical problems remains a critical problem in the United States healthcare system. It is a problem that for years has been resistant to the best reform efforts. No matter what organizations have attempted to do, they are plagued by this problem. Before highlighting two specific defects in the emergency room setting, it is important to underscore that these problems have real consequences on patients. Delays lead to poorer patient outcomes, up to and including the death of patients. This is especially true for patients who go to the ER with heart attacks and strokes, where timely interventions can be the difference between life and death. In my opinion, there are numerous defects that exist in the ER that explain these long waits. However, I will focus on two. The first is an outdated triage system that is implemented at many hospitals. In the triage system, a nurse is positioned as the entry point into the ER. This nurse asks a handful of questions to determine what the main presenting problem is, and also collects a handful of vital signs to assess the patient. However, this nurse may lack the training or qualification to appropriately assess the patient's condition, and the questions may not get to the heart of what the real problem is affecting the patient. Also, vital signs are little more than a snapshot, especially if a nurse does not know the patient's baseline values to detect what changes may or may not be meaningful. Then, after completing this incomplete triage assessment, a patient often waits and waits until they can see a doctor. This is most definitely a defect. A better approach would be for the patient to have vital labs and other diagnostics conducted prior to this wait. This would get information into the hands of a doctor much more quickly. A second defect is the fact that the physical layout of an emergency room is often fixed and static. There is a certain amount of beds configured in a certain way, with various nursing stations dotting this arrangement. But even though the layout is static, the patient inflow is anything but static. Different days of the week and times of the day will have very different patient inflows. The recent COVID-19 pandemic also illustrated that there may be dramatic surges at times in emergency room utilization, and these same surges may also happen due to local natural disasters, for example. Our current ER setups do not allow us to respond to these ebbs and flows. Instead, they act as a constraint on our ability to provide top-notch care. Therefore, hospitals and administrators need to give this issue careful thought. Some of the barriers can be overcome by looking for flexibility from other sources, such as flexible headcounts and surging employees based on patient needs, but this alone will not be enough to entirely mitigate the problem.
Thanks, Natalie. We have shown you the tests in targeting overcrowding in healthcare emergency setting as parts of our process improvement strategy. Anna has developed a process map which Angelina used to identify wastes and defects. Chase and Natalie have shown us ways to reduce waste and defects. Other tool that we are going to use is to reallocate the facilities and use technology to assist us in the triage process. Reallocation of facilities will entail reallocating extra rooms at the department as per the patient flow and needs, and rerouting of circulation based on visitor or patient needs and procedures. We also need to prioritize reallocating more bed space from the least common emergencies to the conditions that are most frequently reported at the emergency department. To be able to do that, we have to have an efficient automated triage system. Integration of artificial intelligence in the triage process for automation enable a faster process of triaging and stabilization of patients, especially those who are critically ill. Integrating artificial intelligence would also streamline the patient inflow and augment the function of the current staffing capacity at the department. So to measure our progress in the process improvement in the emergency department, patient inflow and care data will be collected using a post-change implementation survey with the healthcare staff at the emergency department as the respondents. The data collected using the survey will be analyzed in comparison with the baseline data to measure the success of the change. The success indicators for this project will include reduced emergency department overcrowding, decreased emergency department mortality rate, less waiting time, and lower emergency department healthcare cost. Overcrowding at the emergency department remains a significant healthcare challenge responsible for a high preventable mortality rate. There is a dire need for a change targeting emergency department process improvement to streamline the patient inflow and emergency care. The proposed change would entail clean management, reallocation of emergency department facilities through prioritization and integration of artificial intelligence in streamlining emergency triaging will be phenomenal in reducing the current overcrowding at the emergency departments. It has been the last 5 presentations. We appreciate you spending the time to watch us. Thank you.